So I put bolus of antibiotic in the medullary canal, vancomycin, tobramycin, or whatever antibiotic is sensitive to, and give as wash, as you said, with dilute betadine, and I add dilute formalin also for the wash.
Okay.
I want to have your opinion, and I am telling you since last 5 years I have no recurrent infection.
So I asked it yesterday already, any place for local vancomycin or antibiotic powder locally? If you are performing a 1-stage or a 2-stage, or even in primaries or revisions, do you put in some local antibiotics in the femoral canal?
No.
Like vancomycin or something? No. No, I'm not doing it at all.
Second question is, when do you add antibiotic to the cement? At what stage of mixing?
So if you add antibiotics to the bone cement, it has to be just in powder form, no liquid, just powder form. And then first you mix the powder, the antibiotic powder to the bone cement, and then you put in the liquid and prepare the cement.
Okay.
One additional tip would be you put a little bit of cement powder, antibiotic powder, cement powder.
Yeah.
That really enhances that.
We call it pharmaceutical mixing, yeah. Mm-hmm.
Third question is, when your culture is negative and you see pus over there, please do biopsy also.
Of course.
Because tuberculosis, I've got 6 cases of tuberculosis of the hip and the knee,
Yeah.
in my experience.
Very, very good recommendation, especially here in India.
All cultures biopsy, and all biopsies tissue culture.
Culture negatives should be also...
In this country,
examined.
yes.
TB is important.
Yeah.
Okay. Thank you very much.
I wanted to know the panel's recommendation for dry aspirates from the hip, and what are your tips to yield a good aspirate? And do you go in for an open biopsy, or re-aspirate is also dry? Then what do you do?
Very good question. You want to aspirate a patient, but it's a dry tap. You don't get any fluid out of the joint. What are you doing? Do you dilute it or
Yes.
put in some
Yes, we put about
saline?
20 ml saline, then aspirate that saline, and then send it for culture.
Some other...
For that,
We
you have to
have
ensure.
radiologists, so ultrasonography way they can find out the pockets of pus, and there you can selectively aspirate.
If it is a dry tap, you have to be 100% sure that you are right in the joint. That is another important thing. And number 2, probably USG people might be helping you much more better. If the dry tap, then they can take a biopsy, what is called that with the Gemcity, a true cut. So it is much more easier to get a representative specimen also.
The saline can also be used, but that is controversial. That can dilute your sample, but it can be used.
Yeah, it's still under discussion, to be honest, dilution or not. Some microbiologists are saying this is reducing the number of bacteria dramatically, and then you cannot really find them. Some others say, some Chinese papers are saying it's okay, you can dilute it. I think in this case, some kind of open biopsy is the best way. Open biopsy or via a trocar or something like this.
So I have a question regarding the dual mobility. Like you said, you should use dual mobility in this case. So there is an article about the jump distance, and what they have found is that for the modular type of dual mobility, the jump distance between 36 mm fixed bearing and the modular dual mobility is almost same, even if you keep on increasing the size. It is only the true dual mobility that gives you that huge jump distance that we are looking for. So, like, how do you look at it? Even if you can get a 40 mm head in it, it has a better jump distance than a modular dual mobility.
No, at the end of the day, it's size of the head. So what is the size of your head in dual mobility? That's the question. So from company to company, it changes. So whatever is the, the bigger size of the head has got more jump distance. You can't argue
No,
against that.
they have given a graph that the head is increasing 36, 40, 42, 48, up to even like 56 size of head.
So what they are referring to is there are different types of cups. The sub-hemispherical cups will have lower jump distance. But if you have a fully hemispherical cup, at the end of the day, it is the size of the head. You cannot, it's just common sense. Bigger size head will give you a bigger jump distance. We're not talking about anything else. Jump distance will be bigger, provided the circumference of the cup is 180. So that's where it. So the other thing people always say is, what do you call that? The hemiarthroplasty. Hemiarthroplasty more stable or dual mobility more stable? What do you think?
Hemiarthroplasty is what?
For a given socket size, the hemiarthroplasty will have a larger head. However, for a dual mobility, you are closing the cup more. So that by you are adding
What
on to this.
argument they are giving in that article is that when you are using a modular type of dual mobility, you are actually lateralizing the hip center, and that is which is depleting the advantage of larger size head.
A point well taken that monoblock dual mobilities are more jump distance. Point well taken. Yeah. Okay.
Okay, thank you.
My one question is for you, like when you have done that revision, like you do massive excision, debridements. So like what are the tricks to close the soft tissue around that stem that it does not dislocate? Because when we, and what are the materials you use? You use some like fiber wires or something to put the tissues back on the stem.
No, I try to suture any kind of soft tissue that I find there to close. Sometimes it's not there due to the debridement. The stability and security is given by the dual mobility cup that we almost use in every case. And no special technique. Just close it. Just suture any kind of soft tissue that you can.
To the implant?
Not to the implant. No, not to the implant.
So you don't suture anything onto the implant?
We don't fix anything on the implant itself. No, never.
So like one side we saw a case of polio paralysis where the abductors were there and they were loose, so there is a high risk. So no risk of dislocation if you just don't close it to the implant, like we don't suture tissue backs to the implant.
Yeah, I don't suture anything to
we can just leave it as such.
Yes, exactly.
Thank you.
Now, can I make a comment on, so Thurston comes every year and talks about single stage and we all still on two stage. So the point now is the evidence seems to point, now that Thurston is there, I want to make a message to the audience that just because you leave some antibiotic cement inside for 6 to 8 weeks, it does not aid any way your infection control. Am I clear on what I'm saying? So we think, just like leaving drains we thought will lower infection rate. That's what we thought for a long time. It took us a lot of convincing to say that drains really doesn't affect. But intuitively we like to think like that. So we all intuitively think that leaving a cement spacer inside for 6-8 weeks, we are going to get rid of the infection. But evidence says that is not the case. Am I right, Thurston? Evidence says not. So intuitively we are thinking, otherwise there's no difference between 2 stage and 1 stage. There's no difference at all.
No.
We just think that leaving some antibiotic spacer will sort of sterilize the wound. But that doesn't seem to be the evidence. That's the point I want to make to the audience.
So can I just put a point over it?
Very short.
The issue is, why I am using a dual stage, because when you are doing, after the first stage, most of the time infection subsides and we can put in a definitive implant. But the issue is, the first stage we are giving a very soft partial fixation. So infection is being controlled by the debridement. So if you do a definitive implant with good fixation and the infection is not cured, taking out that well-fixed implant will further deplete the bone stock.
So I think we undermine host immunity also. You have to, it's a very complex situation, you know. So we have to see look at the patient, the immunity status of the patient. These things are also important.
It is what he was talking about, 1.5 stage.
All those factors are there, but the only advantage you can say for a 2 stage is that you get 2 chances debridement.
Yeah.
You can take it 2 times or do it once.
And
it's a choice.
Exactly.
But nothing else changes. That's my point.
If the infection has to cure, but the 1.5 stage he was talking about in a case presentation, that is the same thing. They do a half-hearted fixation and then they leave it as such if it is
No, it's
doing
not
good.
that actually. In 1.5 they put high dose antibiotic into the cement matrix. That's the difference.
Thank you very much. Next.
My question to the panel is, you talked about the infection, to rule out infection. What if there is a suspected case of tuberculosis, hip? So how do you go about it? Do you start the anti-tubercular therapy and do the replacement in the coverage, or do you wait for some time and then go for the replacement?
Very good question.
I have done a lot of work on this. I presented a paper in JOI 21. So it is very important. There's a medical treatment for 3 to 4 months is very important. All parameters should come down. Then one more parameter which is very important is a host immunity. And one small parameter is CD4 count, which should be, from my study, it should be 600 before surgery. So that gives a good immunity and your higher success rate, patient can tolerate better. So minimum 3 months of TB, anti-TB medication, parameters coming down, and then you can do your cemented or cementless. If you are doing cemented, you can add streptomycin just for additional benefit, and you can do both cemented or cementless. And I've done about 52 cases with not a single recurrence with this protocol. CD4 count is very important for the host immunity parameter.
Actually, I presented a paper in Gothenburg for the CCOT meeting on tuberculosis hips. So what I would like to say is that there is a remarkable difference after completion of AKT. When you open it in the fresh tuberculosis, the bone is like butter, it's like putty, it will not take any implant. But after 6 weeks to 3 months of AKT, everything improves quite dramatically, and then you can actually put in your implants. And I also think that cemented implants are probably better, not just because of the streptomycin which you can add, but also because I think the hold is better with the cemented implant.
Thank you very much. Next.
So I've got 2 questions, 2 parts to the question. 2 repeated dry traps and culture negative. What is the perspective on leukocyte PET CT, which they say is coming up big time because it can isolate the site of infection? Second part of the question is, if we get this situation wherein we don't get a culture and then we need to do a spacer in a 2-stage, would you do an empiric antibiotic impregnated spacer, and which will be your choice of antibiotics? If not, would you do a first stage debridement explantation and then do a culture and then coming stage for a sensitive antibiotic spacer?
So can I take that? So the current evidence says there's no role for PET CT, any kind of PET CT in PGI. Okay, so that doesn't. Now our culture negative infections are now 20% in our unit. So even after you open it up, send 5 cultures, tissue samples, still you don't grow any bug. So that's not uncommon at all. And there we have protocol, we use vancomycin, broad spectrum antibiotics, and we use that pretty routinely that comes. You have to assume that your chance of success is going to be slightly lower, but it's not uncommon in this country at all. We see it very, very commonly. Culture negative PGI.
Last question.
After doing the first stage of the revision, and for the first, the bug was isolated with an aspiration which was done preoperatively. For 3 weeks, the CRP was going down. The 4th week it started coming back again. Clinically, the hip is silent. There is nothing there. So what do you do?
You wait with the antibiotics, and you might need to go in again and change the spacer.
So redebridements are common.
So only on the CRP one value, or you would like to repeat it for a few times, because see, he may be having something else also, like a urinary infection or something.
So one CRP high can be an indicator of something else going on, but if the CRP is sustainably growing, that means your debridement has failed. I think we should go in and debride again.
So, but the CRP says it is 20. And it is, if you repeated this thing and it comes hovering between 15 to 20, and only CRP is the issue. You repeat the aspiration is negative. You still like to revise the spacer?
No, I think you have to be a very clear principles here. So you have sequential samples, CRP progressively increasing means you have to go and debride. Otherwise, why bother CRP every 2 weeks? No, that's the whole reason. The whole reason why you are doing CRP every 2 weeks is that you want to see whether should I redebride it or not.
And the other thing is, sir, we cannot sit on it. You cannot sit on it. If you keep sitting on it, you are never going to have a second stage.
So if the CRP is remaining high, it is not increasing, say it is between 15 to 20 each time you are repeating, and clinically it is silent.
Don't rely only on CRP, as he has said correctly, which is a false parameter. You can do aspiration and other tests.
So the aspiration is negative here. I have done the aspiration.
You can do other IL-6 and other tests.
Aspiration does not only mean the culture.
Probably
the cell count, the PMS, the leukocyte esterase. So there are many things in aspiration apart from culture.
If CRP has gone up and it is static for a couple of weeks, probably you may correct answer to me, 1/3 of the patients are unlikely to reach below the normal level.
Absolutely. So we know that the CRP reaches, in many cases, reaches his normal level after 1 year, up to 1 year. So don't rely only on the CRP. It's always a combination of the laboratory parameters and the clinical decision. If the clinic looks good, the patient is pain-free, there's no redness, no swelling, nothing, then you can wait and observe the CRP, in my opinion. So if any other things are okay, see and wait.
So we wait for another, so how much time? So it's maybe 3 months with the spacer inside?
With the spacer inside, if the CRP is not going down, I would wait a little bit longer, but on a certain point, you have to exchange it. And then you have to decide it during the surgery if you do the reimplantation or put in another spacer.
Thank you.
So what is the cutoff of keeping the spacer? Is there any cutoff of keeping the spacer?
No, not really. There's no cutoff of there are some, for example, leukocyte esterase is a very good test which can guide you to do the second stage. So just do a puncture if you're not sure that when you could reimplant. There's a study from Pavisi that shows that if you have a 1+, just 0-1+ leukocyte esterase test, then you can be almost sure that it's not infected anymore, and then you can reimplant.
So keeping the spacer inside, the CRP trend is following, though the CRP is not reaching normal. The trend is following. And the clinical parameters are okay. So can we think of doing a second stage at that?
Yes, yes. Okay. You don't have necessarily to wait until the CRP is on a normal level. The tendency, the trend
should fall.
Yes.